Dr. Finseth is a movement disorder specialist for the Aurora Neuroscience Innovation Institute in Milwaukee. He provides management of movement disorders, including Parkinson's disease, tremor, dystonia, and deep brain stimulation programming, and performs Botox injections for dystonia and other conditions. We are extremely proud as well that he's a member of WPA's Medical Advisory Committee. Welcome, Dr. Finseth.
Thank you. All right. Well, great. Well, it's great to be here. Thank you for putting on this symposium. And so I was tasked with talking about medications in Parkinson's disease and medical management. So we'll get started. So some disclosures: I've received consultancy fees from AbbVie and Medtronic. So our outline as to what we'll talk about today is we'll cover some things about Parkinson's disease that I think are important to then understanding how medications work, and that's talking about how dopamine is involved in Parkinson's disease, and then how the stage of your disease might affect your medication response. And then we'll talk about the actual medications themselves, how they work, and some basics about how we might make adjustments, and some of the advantages and disadvantages of the different medications. And then lastly, we'll talk about some of the advanced therapies, and these would be infusion therapies, and why people might start to use those. So there are different categories of medication. What we've been searching for are neuroprotective medications that would slow down the disease or stop the disease, and we really don't have any of those yet. There's some question and research about whether exercise or DBS might have a mild neuroprotective effect, but that is not proven yet. There is medications used to help symptoms that involve movement, so to help ease movement, and that'll be the focus of this talk. And then there are medications that are used to help symptoms that are non-movement related, such as thinking problems or hallucination problems, problems with blood pressure, urination, sleep, etc. And we will not be focusing on those in this talk. So first we'll watch a video showing somebody with Parkinson's disease. And we see here a rest tremor. The patient's limb is relaxed and their arm is tremoring. And that can continue while the hands are out in front of them, and can continue while the patient is moving their hands. We see some decreased movement in the face there with the decreased eye blink. And then as he's doing repetitive movements, the movements are slowed and they get smaller and slower as the patient goes. And we see that as worse on this patient's left side, which is common in Parkinson's disease to have some asymmetry. And then he has a decreased left arm swing as he walks, and his tremor emerges as he is walking. And so this video is of a patient with early stages of Parkinson's disease and exhibits rest tremor, this difficulty moving, which is characterized by slow or small, and a fatiguing movement that gets harder as you move. And then we can't see the patient's stiffness, but likely if we were to move them around, move their muscles around, we would feel some resistance. That is a part of the movement problems in Parkinson's. And then there can be additional movement problems, such as a difficulty regaining your balance after you lose it, or an abnormal posture of the trunk. And then people can have difficulty moving their feet as they walk, usually maximal when they first start to walk or change direction, where the feet feel stuck. And then sometimes the limbs, such as the foot, might turn or the toes might curl, and that is a part of Parkinson's. So to talk about dopamine, the dopamine is central to the movement problems of Parkinson's. Our normal dopamine system um, consists of a area that produces dopamine down in the lower part of the brain called the brain stem. And this is the factory for dopamine. And then that is transported up and used in circuits up in the higher parts of the brain. And you could think of these circuits as the engine of the brain, and that they help you move, and that the dopamine is like the gasoline that helps that engine work. Well, what happens in Parkinson's disease? Parkinson's disease primarily affects this brain stem when it first starts. And what we see is that the gasoline factory is affected and people produce less dopamine. And so they get symptoms like the symptoms we talked about with tremor and difficulty moving due to their engine not working. And it's due to their engine running out of gas, is a way you could think of it. And due to that lack of dopamine, people get these symptoms. So what happens in treated Parkinson's disease is that we give pills, and those pills replace the dopamines that's lost, and that dopamine would then restore the normal level of dopamine and help the engine run more smoothly. So it's like we're replacing that gas that our patients are missing. And so, how to talk a bit about how Parkinson's would progress clinically is that patients often have symptoms leading up to their diagnosis, then they get diagnosed, and then go through an early stable period where often uh, people are on relatively simple medication regimen and often have a good response. And then over a period of time, and certain patients in particular might develop what are called motor complications, where the medications work inconsistently and may wear off in between doses, and sometimes can develop some extra movements that are called dyskinesia that we'll talk about later. And people would need medication adjustments during these times to address this inconsistency. And then over time, patients do develop symptoms of movement that are resistant to replacing that gasoline, and where the medications are not able to counteract some of those symptoms. And that's more characteristic of late stage Parkinson's disease. And then cognitive issues can occur and are more prevalent at the end of Parkinson's disease, but can occur at any point. And how we might view that in terms of how Parkinson's is actually affecting the disease is that before people develop any movement-related symptoms, Parkinson's is present for likely many years prior to onset of movement symptoms. And people can have things like depression or problems where they act out dreams in their sleep during these times. And then when people get movement problems with Parkinson's, it starts to involve that area that produces dopamine called the midbrain, and that's part of the brain stem. And it's primarily a kind of a gasoline problem in the brain, and we use medications to boost that gasoline. And then later stage Parkinson's disease, the Parkinson's disease itself, which is a protein that accumulates in the brain, starts to involve more of the engine part of the brain. And so while there still remains a gasoline problem, there's also an engine problem. And so that explains why people develop symptoms that will often not respond to the medication. And these might be problems with swallowing or problems controlling their posture, or a certain type of balance problem where you can't right your balance. So the goals of our medications for movement would be to reduce the symptoms that are occurring in Parkinson's disease. And so I've made a list here of the symptoms, and some of them we expect to be a little more responsive to medication, and others are less responsive, and some often do not respond. But we do expect that the stiffness, the slowness, and the tremor will respond to medication. There is variability between patient to patient in terms of how much each one will respond, but all of them have the potential to respond. Often we can make improvements on a shuffling walk, and often using physical therapy helps improve that even further. Freezing and dystonia can also improve with medication. And whereas these last four symptoms that I listed here often do not respond to medication, and you would think of those as a little more of like a engine problem in the brain, and that's part of why they don't respond as readily. And so when we on that earlier diagram, I showed that people transition from an early stage of Parkinson's to where they might go into what's called advanced Parkinson's disease, which is defined by the onset of what are called motor fluctuations, dyskinesia, and often people start to take medications more frequently. And so we'll kind of look at why does that occur, and we'll go back to our diagram with the gasoline in the engine. Well, what happens is that basically this storage facility here, where when we give medications, the brain is able to hang on to those medications. Well, the brain can no longer temporarily store that medicine, and so the person's response to the medication relies on us delivering it steadily. And so medications can wear off in between doses, and due to some kind of oversensitivity of the brain to the medication, it can sometimes go into what we might think of as overdrive, where people get extra kind of flowing movements called dyskinesia. And so this would be the changes that are occurring in the brain that cause people to move into that next stage. And so just to show an example of what dyskinesia looks like, this patient on the top is exhibiting dyskinesia, and these are kind of flowing random movements of the trunk that I'm kind of demonstrating as well. They tend to be worse when the patient is trying to move or speaking. And so that's what dyskinesia looks like, just so you can recognize it if it's occurring in you. And then over time, and this is also variable from patient to patient, is that people might develop an inconsistency in how their pills absorb. And this is often due to a change in how the stomach moves and how it empties. And there's often a delay in the stomach emptying, and the medication does not get absorbed until it's actually in the intestine. So the medication does have to empty from the stomach. And sometimes this can result in an unpredictability of medication response, where medications might not kick in for a prolonged period of time sometimes, whereas they might kick in more quickly at other times. And that can introduce some difficulty in trying to maintain steady levels of the medication. All right, so we've talked and focused on some important aspects of the disease that can affect medication response. Now we're going to talk about the medications themselves. And this is a diagram I drew, pardon the infantile drawing here, but I think it'll help explain how dopamine works in the brain and how we use that system and modify that system. So what we're looking at here is this um, uh, triangular shaped thing here is supposed to be a nerve, and this nerve is coming from the area that actually produces dopamine, that gasoline factory that we talked about. And then down here is the nerve in the engine that actually receives dopamine. And how nerves communicate is through chemicals. So one nerve will release chemicals and it'll bind to another nerve and induce an effect. So this D is meant to represent dopamine. And so how dopamine works is it gets released into this space in between the nerves, and then the dopamine binds to a receptor here, which is the yellow part of the drawing, kind of like a key would fit into a lock. And what happens is you get easier movement as a result. Your engine works well. And then dopamine gets broken down within this space into byproducts that don't have any physiologic effect. And then here we have the brain, and this dash line is representing a barrier in between the blood and the brain. Okay, so our main way that we kind of change the system is by using a medicine called levodopa. And there's various brand names for this: Sinemet, Rytary, Duopa, Inbrija. And these all would add levodopa to somebody's system. And how levodopa works is that levodopa is designed to cross the blood-brain barrier, whereas dopamine itself cannot cross that barrier. And then it gets into the brain and actually gets converted into dopamine there. And then that dopamine, that extra dopamine, is then able to ease movement. Now, the carbidopa part of the medicine is actually a separate medication, and this is designed to stop levodopa from being converted into dopamine while it's in your blood. And carbidopa cannot get into the brain to stop that process in here. And so what carbidopa does is it stops the dopamine from getting broken down out there, because dopamine in your blood causes you to become nauseated and lightheaded. That is the main side effect of the medication. So it doesn't do a perfect job, but it in most people is able to prevent this side effect. And it also keeps the medication around so you can absorb more into your brain. Another class of medications we have are called dopamine agonists, and these would be synthetic drugs that are not dopamine themselves, but they are designed to look enough like dopamine that they can bind to this same receptor and also induce easier movement. And these medications would be called pramipexole, ropinirole, rotigotine, or apomorphine. And these have some advantages in that they're overall longer lasting medications. A disadvantage would be that the dopamine agonist is going to look like dopamine while it's in your brain, but it also looks like dopamine out here in your blood. And so it's going to have more problems with nausea and lightheadedness compared to the levodopa, which is a bit more compartmentalized, where it's only active where you want it to be in the brain and tends not to have much activity out in the bloodstream. And then we have what I would term as dopamine extenders, and these would be medications that, by stopping your body from breaking down dopamine, they act to boost dopamine. And so you can stop dopamine and levodopa from getting broken down out in the bloodstream, which entacapone and apicapone do, or you can stop dopamine from being broken down in the brain, which is what rasagiline, selegiline, and safinamide do. All right, so that's how the medications work. And then to look at kind of how the medications vary in terms of how long they last. So the dopamine, we'll just focus on the top part up here. These diagrams indicate medication level, and the x-axis is time, where most medications will peak after you administer them and then slowly fall away. And so medications like the dopamine agonists or a medication called mantidine are going to slowly degrade, and about 12 hours later you might have somewhere around half the level of the peak dose, whereas there are some extended release medications that are going to work on a longer time scale here and are more dosed every day. And these medications are useful because they are able to maintain kind of a steady level. And long-acting medications build up in your system, like this diagram shows here, where after a certain amount of time, the medication really never fully leaves your system and kind of goes up and down on a baseline. And that's very useful for trying to keep medications stable. Whereas down in this bottom part of the slide, we show the different formulations of carbidopa-levodopa. And these medications are much shorter acting in general. So, it's kind of complicated here, but the yellow graph here is the medication Sinemet immediate release. It's the most commonly used medication, and this peaks immediately and then kind of falls off. And by about 4 hours later, you only have maybe a quarter of the medication left. And then there's something called Sinemet CR, which is the green curve here, or a medication called Stalevo, which is the blue one. And those last slightly longer, but don't kick in quite as readily, and are fairly similar in terms of their dose response curve here. There is a medicine called Rytary, which is designed to last longer. We do see that it's able to achieve some steady medication levels for a longer period of time before it falls off. And then there is an infusion of carbidopa-levodopa called Duopa that is able to maintain quite consistent levels of the medication throughout the day. All right, so let's talk about how we might treat patients during these periods and how that might change over these periods, the early stable and when people start to develop motor complications. So in early Parkinson's disease, typically by convention, we would dose carbidopa-levodopa 3 times a day. And the medications rise and fall in somebody's bloodstream, but people have a consistent benefit to the medication. And that's likely due to to patients hanging on to the medication in their brain. So even though the blood levels rise and fall, their brain level per se is consistent. And then over time, patients start to develop motor fluctuations. So these are fluctuations in the medication response. And there becomes a window here where there's an ideal kind of range where the medication would optimally be for controlling symptoms. It's not too high and it's not too low. And what happens on this graph is that after you dose the medication and it starts to come down, you might fall out of this what's called therapeutic window. And when the medication level falls out of it, people start to experience reemergence of their Parkinson's symptoms. And that's called off time, where the medication has worn off, and it tends to occur most commonly at the end of a dose. And then after another dose, the medication level would rise. They would then again feel on, where their symptoms were relatively relieved from the medication, and then experience off time again at the end of a dose. And uh, at the peak of a dose, some patients do experience that dyskinesia movement, which is indicated here by red, and that tends to occur when the medication is at a high level, um, and that is this patient, if this was a patient of mine, we would need to make adjustments to try and keep them in this therapeutic window for more of the day so that we could improve their function. So to talk about, what are typical patterns of these fluctuations? Well, we talked about it's typical for it to occur at the end of a dose. Often it's kind of a slow wearing off, a gradual wearing off. It becomes more problematic when it's a more sudden event, and that tends to occur later in Parkinson's disease, and not in everybody, but can occur in some. And then that the dyskinesia that tends to occur at the peak of a medication dose when the medication's too high. It some variations on this theme is that these sudden off periods, or people might have some random off periods at times they might not expect. They might have a weak response at the end of the day, or sometimes they might take a medication and it never kind of kicks in, and we think that that's due to the stomach emptying problem. And then when the medication wears off, it sometimes can cause a painful cramping in somebody's foot, typically. And then it would be less common for people to have dyskinesia, those flowing movements, when the medication wears off, but that can occur. It can occur both at the peak of a dose and when the medicine is at a low point. That can be very difficult to control. I just want to be clear that when medications wear off, that it's not only movement symptoms that can reemerge, but people can have other symptoms that can be equally or sometimes even more bothersome, where they might experience pain, feel restless, feel depressed or anxious, feel like everything's just kind of wrong, or panicked or sweating, or like their belly is bloated, or they may feel like they have trouble controlling their breath, or like they have to go to the bathroom all the time. And so that's important to recognize that those might be due to medication fluctuations and could be addressed by changing the medications. And so how do we actually address these fluctuations? Well, we would do this by using multiple drugs or using more frequent dosing. We might use extended release of medications, using rescue medications, or going to a more advanced therapy like Duopa or deep brain stimulation. And I will talk about Duopa, but Dr. Swanson will talk about deep brain stimulation in his talk. All right, so how we might use multiple medications. So we might start dosing more frequently, that same carbidopa, levodopa, immediate release. So if you think about that patient that was having those problems earlier, if you made these adjustments, it might help improve it. So adding amantadine, what that would do is actually raise the ceiling of your therapeutic window by suppressing dyskinesia. So we're actually able to use a little more carbidopa, levodopa by using amantadine. And then rasagiline was one of those dopamine extender medications that's dosed once a day. And what happens is that the levodopa will be broken down at a slower rate. And so it tends to last longer. So instead of declining kind of more quickly, it declines at a less rapid rate. And so it might go from let's say, lasting 4 hours to 5 hours. And so that would be a way that we might use medications. Another thing we might do would be add a dopamine agonist medication. And those are typically dosed 3 times a day or the extended release once a day. And what those do is provide kind of a steady level of at least some medication with dopamine in it that can provide kind of a floor. So that you would never go below, your medication would never go below. And that can be quite helpful. So the dopamine extending medications, we went over kind of how those work. And in the studies that looked at the amount of good, the change in good time from before the medication to afterwards, we see about an hour improvement in terms of good time for patients in the studies on those medications. For dopamine agonists, we talked about what the names of those. I just want to say that they are very consistent, and that's great. And for people that tolerate them well, they can be extremely useful. The downside of them is that they have a higher rate of side effects, and the older somebody is, or the more they have any of these symptoms to begin with, the more at risk they'd be for getting those side effects. So it's more likely to cause nausea or lightheadedness than carbidopa levodopa. It causes leg swelling, or it can cause leg redness. And then it can have some central side effects on the brain, where it causes excessive sleepiness or sleep attacks, and a higher risk of causing hallucinations or impulse control problems. And then there is a medication called apomorphine, which is a dopamine agonist, but a little more similar to carbidopa levodopa, but it doesn't last as long as the other dopamine agonists, and is used a little differently, and I'll talk about that later. There is a medication called zonisamide. It's traditionally an anti-seizure medication and has been shown to have some benefits on movement and work steadily throughout the day. And then we have the medication Rytary that I mentioned earlier, that is a more extended release carbidopa levodopa. And converting to that can be quite useful for some patients. In the studies, people went from spending 37% of their day in the off period to 24%. So that's a pretty good improvement. There tends to be people that really benefit from it, and people that converting to this, it doesn't provide them a great degree of satisfaction. And then there are medicines that can rescue somebody from off time. So this would be something you would take in response to an off period, that are designed to be absorbed quickly and get your medication levels up. And there are different options for this. You can use either apomorphine or levodopa-based medications. And they can be injections under the skin. They can be kind of almost like a breath mint, and that's a new medication. There can be an under the tongue levodopa tablet or an inhaler. And then we have some different options for people who their tremor just doesn't seem to respond to levodopa. You might try really high dose levodopa, or you might try some of these other medications. And finally, if those fail, deep brain stimulation of the subthalamic nucleus would be a good option. And then we're running short on time, so I won't spend I only have a little bit of time to talk about advanced therapies, but what these would be is ways that we can really finely control our treatment in a very consistent treatment. So they are good solutions for inconsistency of medication and tend to be highly effective. And after they exert their effect, that tends to continue to be useful throughout the disease course. They do carry a little more risk up front, but are relatively safe and have been proven to have large quality of life improvements for patients that are really suffering from medication inconsistency. And so Duopa and apomorphine infusions would be options for this. We also know that not only can it help smooth out movement fluctuations, but we have seen that it has improvements on some various non-motor symptoms after people have these treatments. And Duopa is the FDA-approved option in the United States now. It's a external pump where levodopa is infused through a tube that goes through the abdominal wall and threads down into the intestine. And we're able to finally control the levodopa level of somebody's bloodstream, and then it's disconnected at night. And so the studies showed that people had about a 4-hour improvement in their amount of off time after the pump was placed, without a significant change in dyskinesia. And there is an apomorphine infusion, which is infused under the skin. This is not yet available in the United States, but has been available in Europe. And there was a study in the United States, and it's awaiting approval, that showed about almost a 2-hour improvement in off time when patients used this medication. Overall, our strategies would be, try and diversify the number of medications we use, try and use long-acting medications if we can, to try and keep track of times that aren't as good, so we can make adjustments. And then if all those things fail, to think about whether we would want to pursue a more advanced therapy. All right, so that's my talk, and I think Jeremy's there ready for questions.
Hey, Dr. Finseth, thank you very much for your presentation. If you could stop screen sharing, that way your screen,
sure.
you'll get nice and large and they can actually see you.
Okay. All right.
Thanks for giving us a great overview of the medications and things like that. One of the things I wanted to touch on that has been asked before, are there new medications in the pipeline that people should be watching for, or are maybe a little more exciting that you want people to be aware of?
Yeah, I think in terms of things that might be available soon, would be that apomorphine infusion, which would be a way to give a continuous treatment. And I think certain patients will be better candidates for that, but the results from both that study that was performed in the United States as well as from experience in Europe have shown it to be a very useful treatment. And then in the pipeline, in terms of along that same line, there is some looking at infusions of levodopa-based medications that would also be under the skin. And so we don't know how those will work out, but that's more maybe 3 to 5 years out. But those could be helpful. There's also trials on other ways to control dyskinesia. For certain people, dyskinesia is a big factor in their loss of quality of life. So it'd be nice to have more than just the amantadine in terms of suppressing dyskinesia.
Okay. And I think the part that's encouraging to people with that is, even though we're in a pandemic, medications are still being studied and researched, and hopefully will be coming out in the future. Not that we're just taking the status quo and staying where we are.
That's right.
The other thing you touched a lot on the medications, and you commented at one point, this doesn't work for everybody. I hear a lot at support groups that, well, I'm on this medication, you should try this. That doesn't always work. And can you maybe, from a physician perspective, kind of say, here's why not every medication works for everybody, and why we as physicians try to rule things out, and maybe takes us a little while to find the right mixture of medications to treat the symptoms.
Well, sure. I think it's complicated as to who gets put on what medication. Ideally, any medication would be very effective and have no side effects and be inexpensive and be simple to dose. But our different medications have, none of them have that same, all of those qualities. And so both working with a patient on what they value, as well as looking at what symptoms are they already experiencing, like are they already getting lightheaded or already having hallucinations, or how old are they, might tell us about how likely they are to have side effects from the medications, as well as there are just some factors that are hard to predict, where some people just seem to have a very beneficial response to certain medications, where other people, it really doesn't seem to do a whole lot for their movements. And so it, it it's it's hard. It's a complicated decision that goes into it, and not it's not like one drug works for everybody, or one regimen works for everyone. That would be just too easy, and unfortunately, it's not that easy. And so I think bringing those ideas to your doctor and saying, "Hey, somebody recommended this. Would I be a good candidate for this?" And having those discussions, I think is good. But your doctor might say, I don't think that is a good option, or they might agree. So I think you just kind of have to have those discussions with your doctor.
So what I'm getting out of it is everybody is different, and it's good to talk to your doctor.
Yes, yes.
But I think that's important. I think people do forget that once in a while, that it's not a one-size-fits-all disease, and I think it's important to have
Right.
open communication with your healthcare provider. And kind of along that vein, I think the last question I'll ask you is, with everything that's going on, with the pandemic, people being at home, maybe not as engaged socially, exercise, et cetera, that we have been in the past, what are the things you're seeing within the clinic that maybe concerns you and people should keep an eye on, and definitely should be reaching out to their care provider if they're noticing any of the things that maybe you've seen pop up in the last 6 to 7 months?
Yeah, I mean, I think the main thing that I've seen consistently is people telling me about problems they've had due to changes in their activity level or their social arrangements. And we didn't talk at all about sort of physically based treatments, or like physical therapy or exercise. Those are obviously very important, and I think this pandemic is teaching us that and reinforcing that. But patients are telling me about declines in mobility or declines in sort of their mental well-being due to removal of those things. And so I think trying to be conscious of that and trying to adapt as best you can, by finding other avenues to stay physically active, even if it's not what you were used to, or other avenues to stay connected, that that can try and replace as best you can kind of what you're missing because of the pandemic. So I think that's been the main change I've seen in terms of how people are doing with all that's going on.
Perfect. I appreciate it. So I appreciate your time as always. We really enjoy having you come in and present to us. I'm sure the audience does. So thank you very much.
for you, and how I can get you out of my memory. In the darkness there's a picture of you and me, and if I look back, broken remembering, I know, afraid I will never be.
All right, welcome back. We are live with our final presenter and the final of the three great doctors that we have presenting for you today. This will be Dr. Kyle Swanson, who's a neurosurgery specialist at Aurora St. Luke's Medical Center in Milwaukee. He has over 12 years of diverse experience, especially in neurosurgery. He's going to be talking about DBS. Welcome, Dr. Swanson.
Hello, and thank you for having me. I'm looking forward to talking about how deep brain stimulation offers a chance to restore function, especially for patients with Parkinson's disease. Let's see. So first off, I don't have any financial disclosures. As mentioned, I'm a neurosurgeon. I work out at Aurora St. Luke's in Milwaukee. I focus especially on movement disorder surgery with deep brain stimulation. We also do epilepsy surgeries and procedures for pain, and then a whole lot of other things that neurosurgeons take care of, especially when we're on call. So deep brain stimulation is the placement of electrodes into the brain to allow us to alter the firing of the circuits in the brain. So why can't we just use medications? And I know you just finished hearing a great talk by Dr. Finseth about the medication options. And the mainstay is levodopa and other equivalents. However, we know that at some point, many patients don't get complete control of their symptoms with just medications or develop side effects related to those medications that can limit how much more we can adjust the medications. So one of the things that's nice about deep brain stimulation is that it's another way to treat the symptoms of Parkinson's disease, and you can turn it on and off when you turn the stimulation off. It's used as a second line if medications start causing side effects or if the medications aren't completely controlling the symptoms. So some of the things that it can help with is the on-off phenomenon or dyskinesias related to the levodopa use. So to be a candidate for DBS, we need to first make sure that you have the appropriate diagnosis of Parkinson's disease, and sometimes we'll use a DAT scan to help with that. We want to see that people are responsive to the levodopa because a lot of times the response to DBS is predicted by people improving with levodopa, even if they've developed symptoms that are no longer controlled or have developed side effects. And then another important thing is that we want to rule out the presence of dementia or significant psychiatric comorbidities in order to go forward with DBS. Other things that are on the labeling from the FDA, though these are things that may change with time, is a disease duration of 4 years at least, with symptoms or issues for at least 4 months, such as on-off motor fluctuations, uncontrollable side effects, including dyskinesias, or a drug-resistant tremor. And there are some evidence from studies that have been coming out that moving things towards the earlier time frame provides more benefit. So, once you've had Parkinson's disease for a while, if the symptoms aren't completely controlled or you're having issues with side effects, asking your physician about whether or not DBS would be a suitable treatment for you. So what do we target with DBS? The targets of DBS, there's two of them. There's the subthalamic nucleus, which is deep in the brain, near the junction with the brainstem. And then there's also the globus pallidus internus, which is part of what we call the basal nuclei, also near the center of the brain. Both of these have shown very good effects for Parkinson's disease, and there's very subtle reasons why we may choose one versus the other, but both of these actually can be very useful. So what does DBS help? So in general, it increases on time where you're having good relief of symptoms. It can reduce medication dose, often fairly significantly, on average, nearly 50% for most of our patients. It can improve rigidity and bradykinesia, and it's also very effective at helping with tremor. And tremor is the one indication where even if you didn't get response to levodopa, we can definitely help with tremor. It also can improve medication-induced dyskinesias. Something that's variable is how it affects gait, because walking is something that is, a very complex task. Patients who see improvement with levodopa with their walking oftentimes will also see similar improvement with DBS, but sometimes issues with gait, especially if it's a problem of balance, may not improve with DBS, or sometimes can even get worse. What is DBS likely not to help with, or less likely to help with, or occasionally worsen? So as we mentioned, balance is a more complex thing, and so part of our evaluation, if there's concern for balance, is having the patient be seen by physical therapy. Cognitive deficits, the cognitive effects of Parkinson's disease are not improved by DBS, and one of the contraindications is if somebody has a true diagnosis of dementia. And then depression and mood problems. So these aren't contraindications. They aren't typically helped by DBS. Depending on the psychiatric or mood issues, sometimes we'll change which target we use, but it's something that we do have to consider when deciding about somebody being a DBS candidate. So these are some publicly available videos showing kind of the response to DBS. This is a patient with a pre-operative exam.
Now, put your hands like this. Point your fingers. Get them as close together as you can without letting them touch.
You can see how his tremor comes out
Right.
with that maneuver.
Now, with both hands, go like this. Turn them up to the ceiling, down to the floor, up to the ceiling. Now, go as quickly as you can. Back and forth. Keep going.
Relatively slow, rapid alternating movements with tremor emerging.
Cross your arms and stand up. Let your arms down now and walk circle facing back.
You can see the small steps that he takes and difficulty with turning, and also the unsteadiness he gets with his walking because of those small steps.
Okay.
Here he is after DBS.
And straight out like that. Straight fingers wide apart. Hold them there.
You can see that he's much more steady in terms of his lack of tremor, especially on that right side, even with the postural tremor.
There you go. And with both hands, go like this, back and forth, as fast as you can go.
His motion is a more normal speed in terms of rapid alternating movements.
There you go. Let your arms down and walk back and forth, several paces.
And you can see that his walking is more fluid, his turning is also more fluid. Now, another example of a patient who has very severe tremor related to his Parkinson's disease, and now that the DBS system's being turned on, and within a matter of seconds, you can see that the tremor will quiet significantly. So some of the things to emphasize about deep brain stimulation is it is not experimental. It's FDA approved for Parkinson's disease now almost 20 years ago. It is not a treatment of last resort, and that we have excellent level 1 randomized controlled trial evidence to support its use in appropriately selected patients. So this is the highest level of medical evidence that we can have for a therapy. This is just one example of one of those studies from the Journal of American Medical Association, which showed that deep brain stimulation was superior to best medical management alone for control of symptoms when added to medical management. So DBS on average improved the amount of on time by 4.6 hours a day compared to no improvement for patients who just continued on medication alone. Now, what that means is they had improvement with the medications, but when they continued the trial and just continue with medications, they didn't continue to have improvements with on time, whereas the DBS added improvement above and beyond what the medications provided. The other thing is in all the quality of life measurements, there was a significant improvement in the DBS group compared to the best medical management. So DBS is management for symptoms. One of the things that I always emphasize is it's not a cure. The underlying degenerative nature of Parkinson's disease is not changed. What we're changing is how it affects your function. DBS does not halt the progression of the underlying disease. And I keep hoping someday we'll figure out how to halt the underlying disease, and I'll be put out of business for this thing. That would be a very happy development, and hopefully someday our scientists will figure that out. So looking at how safe DBS, overall the complication rates are low, and it's very successful. This is a series out of one of the places where I trained out of Barrow. In 284 patients, there are no deaths. There are only a few percentage of patients who had some confusion post-op, but that was only brief and none of it was permanent. 1.4% had some bleeding, but most of that was asymptomatic. 1.4% had seizure, 1% had infection. And the mean length of stay, people usually get home by the first day post-operatively. So it's not a long hospital stay. And only about 1.4% of patients had an issue that led them to come back to the hospital within 30 days. And then one of the things I'll talk about more is that the complications between asleep and awake were no different in this study, and I'll talk about why you might choose one versus the other. So just so you know, DBS surgery has actually been around for a while. The initial report was in 1987, so we're now going on more than 30 years of treatment. When we first started doing this, though, we did not have intraoperative imaging, so we had to pass additional electrodes to actually record from the brain to identify those two targets that we use for deep brain stimulation. We would also then do test stimulation to verify the location. And both of these things require that the patient be awake in order for us to get adequate recordings and to see how their symptoms responded to stimulation. So just some discussion of what's involved with awake DBS. The patient must be off the Parkinson's meds so we can observe their symptoms. One of the issues is that in order to do the surgery, we have to have the patient in this specialized frame that holds the head, and that's held in place by pins that attach to the skull. The other thing is that, these surgeries take a little bit of time, especially with all the recording. So the patient has to stay in that same position for a while. And because we're doing recordings of the brain, in addition to putting the eventual electrodes for stimulating, we do have to pass additional electrodes into the brain, which always carries a small amount of risk. And then in order to get accurate understanding of how the patient responds to stimulation, we need the patient to be cooperative, which sometimes surgery is a tough thing for people to stay cooperative for a few hours. So a sleep DBS is something that I went to Barrow Neurological Institute in Phoenix to train after my training at University of Wisconsin. Allows us to do this with the patient under general anesthesia the entire time. And so that obviously eliminates a lot of the discomfort related to DBS surgery. And the reason that we feel comfortable doing this is that we have intraoperative imaging, which can be either MRI or CT. And at Aurora, we use the CT imaging. This allows us to verify that the target that we're trying to hit with our surgery is actually achieved during the surgery, and so that we know that we've got in the right spot just by the imaging alone, as opposed to doing testing and electrode recording. So at Aurora at St. Luke's, the vast majority of our cases so far have been done asleep, though we do a handful of awake cases, usually one every few months, usually for patients who can't get an MRI because of something like a pacemaker. And also we offer the awake if anybody wants that, since that's the more traditional way of doing it, though so far anybody that can has taken us up on doing this asleep. We have all the necessary equipment for awake DBS, and as I mentioned, we have been doing them when needed. So what's involved in getting ready or getting worked up to find out if you're a candidate for deep brain stimulation? First is evaluation and referral by one of our movement disorder neurologists. We discuss all of the information about a patient at our movement disorder multidisciplinary conference, which includes neurologists, myself, physical therapists, our neuropsychologists, as well as our nursing staff. And we come to a consensus as to whether we think somebody's a good candidate. After that, you follow up with me to discuss in detail the risks and benefits and what other alternatives there might be. And then preoperative clearance by your primary care doctor, just like you would for any surgery. And then we also get imaging beforehand, specialized MRIs and CTs. And this is where I make the plan.